from outside Maharashtra. And I welcome everyone, and I request Dr. Anita to introduce our speakers. Anita madam, please unmute ma'am.
Sorry for that. Thank you, Manisha madam. Yes, Varsha. So I am very happy and privileged to introduce Dr. G.L. Ravindra sir. Sir is a very senior anesthesiologist and he is a consultant, chief consultant anesthesiologist at Janki Anesthesia and Critical Care Hospital at Shimoga. And he has hosted the Karnataka ISACon in 2002 as the organizing secretary. Sir was the president of ISA Karnataka in 2003, and his area of interest are obstetric anesthesia. He is a senior consultant and he has performed more than 13,000 labor epidurals. So really, we are really pleased to really are looking forward to listening to you, sir, your experience. And he has had various publications in national and international journals. So with this very short introduction, I welcome you, Dr. G.L. Ravindra sir. Dr. Sale sir.
Sale sir.
Unmute.
Please
Unmute sir.
Sale sir, please unmute yourself.
Sir, Sale sir.
Now it's okay.
Yes. Now it's okay.
Good evening to all. I welcome Dr. Rao on behalf of all my team members. Dr. Rao is a private practicing anesthetist in Mumbai, northern suburbs of Mumbai. He is a undergraduate from Grand Medical College and postgraduate from LTMC, that is Sion Hospital. And over a period of last 30 years, he is doing his practice. And he is a director of Galaxy Healthcare in Borivali. And his areas of interest for him is the oncosurgery, anesthesia for oncosurgery, and anesthesia for laparoscopic surgery. And of course, regional anesthesia. Welcome, sir.
Thank you, sir. Dr. Samir, please introduce Dr. Sadhana, madam.
Hello, Avinash.
Suppository.
अरे unstable है connection. Connection
Okay,
unstable है. OT time me. Hello.
Yeah. Manisha, madam, please.
Yeah. Varsha madam, please put the slide of Dr. Sadhana Kulkarni madam. Sadhana, I don't think Sadhana Kulkarni madam needs any introduction. She is a famous senior respectable anesthesiologist, a motherly figure in Maharashtra, not only in Maharashtra, outside Maharashtra too. And we all know that madam has served our fraternity a lot. She is at the moment professor and HOD emergency medicine and in charge of skill development unit, and presently affiliated to MGM Medical College, Aurangabad. She has huge teaching experience, almost 45 years. And she is also instructor for ACLS as well as BCLS courses of American Heart Association, and an instructor for our IRC guidelines also. Madam has done fellowship in palliative care too, and she has received many awards and has more than almost 80 publications in national and international journals. In fact, it is my pleasure and honor to introduce madam, because we always look upon madam as our motherly figure in anesthesia fraternity. Welcome, Sadhana madam.
Thank you, Manisha, madam. Varsha, there is a lot of disturbances. Please check. Please mute.
This Galaxy numbers are
Galaxy X, yes.
Yeah.
Okay, thank you. It's my pleasure to introduce my beloved teacher, Dr. Pushpa Agrawal, madam. Madam is professor and HOD at VM Medical College, Solapur, and Sri Chhatrapati Shivaji Maharaj Sevapchar Rugnalay, Solapur, Maharashtra. She is affiliated to University of Maharashtra MUHS. Madam was Dean in 2014 and Deputy Dean for 4 years. She had huge experience of 32 years teaching experience. She is PG guide and examiner for MD, DA and DNB. She worked as governing council member in MSCISA and is appointed by university to form a syllabus in medical emergency for degree course in MUHS. She got many appreciation and awards from Jeevan Dayi Arogya Yojana, then for anesthesia for pediatric laparoscopic surgery, from appreciation certificate from Dean Solapur, then certificate from SAS in 2010, then from MSCISA, and she was president of IMA in 2019 and 20. Madam is faculty of the Art of Living course and done many yoga, spine care yoga, kids yoga, meditation, health and happiness programs, and conducted 40 free workshops for police in 2011 and 12. Welcome, ma'am. And with this, I request Dr. Rao sir, Ravindra sir to deliver his lecture. Ravindra sir, please.
Good evening, everybody. Let me start my slides. Yeah. Sorry for that. Yeah. Good evening, everyone. Let me take this opportunity to thank the organizers of this webinar, the ISA Maharashtra State, the President, Dr. Manisha Katikar, and everyone in the audience for having given me an opportunity to speak on this kind of this common topic, commonly faced problem, which everybody faces day in and day out, and have problems in managing, and whether there is any guidelines, whether there are any standards in setting up how we need to manage our failed spinal, how to reduce the incidence of failed spinal, and how to manage if there is one. Now, what is the way forward? It's nearly 120 years. It's about 120 years since the first spinal was given on the 24th of August, 1898 by August Baer on his assistant, Augustus Hildebrand. And so his postulation was that after injection of intrathecal cocaine, there should be some kind of temporary and reversible paraplegia that occurs in a human being. Now, this is what was his postulation. Now, with this postulation, he tried to do the spinal on his assistant. After injecting the subarachnoid injection of cocaine, he tested his efficiency of this procedure with burning cigar, but burning with a cigar butt on the shin of his assistant, and then kicked on his testicles, and then with an iron rod tried to beat on the shin. And Hildebrand was all in smiles. He was not feeling the pain at all. Now, this was the success story. Now, he felt that it was wonderful. The irony was that the first successful spinal was also the first failed spinal also. You see, this spinal, the first spinal, was a dual spinal. The assistant, the boss gave it on the assistant, and the assistant gave it on the boss. Whereas the Baer's block, the boss block worked the assistance block did not work. So the bear was in pain even after receiving the subarachnoid injection. Now, what happened? Both had post-dural puncture headache retrospectively later on. For nearly 1 week, they had post-dural puncture headache. And the fact that both had PDPH, the dural puncture was there with the Hildebrandt block also, but it was considered that an equipment or an operator failure or a drug failure at that point in time. So ironically, the first successful spinal was also the first failed spinal as well. Over the years, the spinal anesthesia has had a roller coaster journey, enjoying the pinnacle of its popularity at one given point in time and coming down to abysmally low levels of popularity at the other time. And today, for probably, as most of my senior colleagues put it in the beginning of our discussion itself, that it enjoys the most popular position amongst the entire anesthesia fraternity as today as it stands. So why is it so? It's because it's a very simple technique, technique. One small single injection at the back has a definite endpoint. You know that if the CSF trips, your needle tip is in the subarachnoid space. It's one of the most reliable techniques. It gives complete surgical anesthesia. I don't think any other technique matches spinal anesthesia as far as the surgical comfort, the complete surgical anesthesia is concerned. With a small amount of one single drug, it gives excellent surgical conditions, operating conditions. And the incidence of spinal anesthesia is extremely low. It is perhaps less than 1%. But there are articles which mention that a very high figure of 17% failed spinal, it seems. Now, if I say 17% failed spinal, I'm sure in the entire audience, not even one would agree that I don't think in our practice, the failure rate of spinal is as high as 17%. But if you go into the details of that article, then you will realize that the definition of failed spinal is different in that article. What he says is that some amount of mild discomfort in the abdomen while doing a cesarean section is considered as failure. If a person develops a high spinal, severe hypotension and bradycardia, it is considered as failure. So any complication of spinal is considered as failure. So when you take that into account, maybe 17% probably holds good. But even then, it is not true. And most of the failures which are talked about are avoidable. If not avoidable, can be managed fairly well if you know how to manage a failed spinal. So management of failed spinal, there is an excellent article which came up in the British Journal of Anesthesia in 2009 with over 450 references. He quoted 4 different maneuvers of including repeating spinal, change of posture for a better spread, local anesthetic infiltration, systemic sedation before embarking onto general anesthesia per se. So it is not that if spinal fails, you go ahead and give general anesthesia. That's not true. So there are different techniques which are described. Now, what do we normally do when our spinal fails? I think this is what everybody does. Look at the brand name. Oh, this drug, that drug. I had told my sister so many times not to give me an oven. It doesn't work at all. Fact that spinal has failed, he doesn't blame, the anesthetist does not blame himself, doesn't blame anybody else. He blames the drug first. After all, how many times to tell? This drug will not act. Why should I be given such a drug? We look at the brand name. This brand is better than the other. This company is better than the other. Look at the batch numbers, which we have never seen in our lifetime. When the spinal fails, we look at it. Expiry date, local anesthetics as such, from the point of view of efficacy, the quality of the drug, the drug is a very stable drug. So in 5 years, it doesn't decay at all. Even after 10 years of expiry date, the drug will maintain its quality as an anesthetic. I'm not advocating you to use it after expiry date. That's not the point. The point is that that is not the reason for your failure. And above all, the anatomic variation of the patient comes into picture first time. The moment I saw this patient's back, I knew there was something wrong. This patient's back is somewhat this way, that way. I knew my spinal would fail. Arey, you blame something else. We blame everything except myself. Everything else is blamed. I did my best. What could I do? The neurosciences division of AstraZeneca received 562 product defect notification reports. Product defect notification reports in a 6-year period between 2001 and 2007, all attributing to failed spinal anesthetics. And they said that bupivacaine solution, which the company supplied, the Sensarcaine, was defective. It came from all over the world, 54 countries in the world. Name a developing country, name a developed country, anything, third world country, every countries were included in that. What the AstraZeneca did was, it appointed a neutral agency to investigate. What was done? Sample from the same ampule by which the procedure was failed was sought, and the neutral agency investigated. Our surprise, analysis showed that the return material was well within the product specification in every case. The drug was not faulty at all. There were other reasons for yours or our failure. So before talking about all that, think why my final has failed. We all know that there are two different, broadly classified two different kinds of failure, a total failure and a partial failure. In my opinion, total failure is due to the local anesthetic drug not reaching the subarachnoid space at all. And partial failure is due to not reaching the subarachnoid space in sufficient quantities. And this is true in 99% of all the failed spinals. And in that small 1% of the cases, there will be some real causes like inadequate intrathecal spread, anatomical abnormalities, some septae or something like that, which blocking the spread of the local anesthetic. Local anesthetic resistance, which is of course a true fact. It is a possibility, especially with a history of scorpion bite. A history of scorpion bite, prior history, puts a person into local anesthetic resistance. The spinal may not act in him. And of course, the last but not the least is the poor quality of the drug. These are some of the causes, real causes, and they account for only 1% of our failures. Gaston Levott in 1922, exactly a century ago, has written that there are two conditions therefore necessary, absolutely necessary, to produce spinal anesthesia. One, you must have punctured the dura mater. Two, subarachnoid injection of the anesthetic agent. And if you have done these two things, the spinal must act. And it is true, even today, after a century, true in more than 99% of the failed spinals. So stop the blame game. Think what is wrong. Now, how to go about? If my spinal fails, what to do? How to go about? There are two landmark articles. Both of them have come from India. Number one came in the World Clinics in 2014. Our good friends, Dr. Sunil Pandya and Ketan Parikh have written it. And in 2018, this time, Ketan Parikh joined hands with Shweta Sitaramaya in the Indian Journal of Anesthesiology in 2018. And this article was Approach to Failed Spinal Anesthesia. And this is an excellent article. I think everyone should go through these two articles. In that articles, what they do is, from the time of recognition of the failed spinal, the spinal has failed, that when you have recognized, from that, they divide it into two broad categories. Number one, if you have recognized it before skin incision. Number two, if you have recognized the failure after skin incision. In these two situations, how to go about. And it's excellent, fantastic way of presentation. No, to a certain extent, I have modified the internal arrangement of these this classification, and to a certain extent, I have made them slightly look a little in a different way. Of course, in a melodramatic way. Number one, before skin incision, you might have failed to do a dural puncture at all. You may have a total failure. That means that there is no sacral anesthesia also, or there could be a partial failure. Now, these are the three situations before skin incision and what to do about them. After skin incision, the pain will be there. The pain, the nature of the pain could be a pressure in one of the situations, and in the other one, sharp pain. These are the 5 situations, and we need to go about and manage each one in a different way. Now, let's go from one by one. Failure to do DP. So with experience, most of us would have learned how to do a dural puncture nicely. Our failure, I think if you ask the failure rate of each one of the audience, it will be much, much, much low. I know it. I know it is true. But what happens is that this is what experience we have just learned it. What we normally do in doing a spinal anesthesia, we take a needle, most of the time midline approach, between the two spines, go between the two spines in the interspinal space, reach that small bony defect between the two vertebrae, which is covered by the ligamentum flavum, puncture the ligamentum flavum, reach the epidural space, puncture the dura mater, arachnoid, reach the subarachnoid space, and do over spinal. This is what is the routine regular procedure. Now, for this, there are minimum 3 prerequisites. Number 1, patient cooperation for this. Number 2, a proper positioning of the patient and minimizing the directional errors, the direction in which we need to go. So the first and foremost is patient cooperation. We need to have an immediate preoperative counseling with the patient. Talk to the patient nicely. Go and touch her. Talk to her or him. Find out. Tell him or her what you are going to do. You're going to give a small injection at the back. And what is going to happen? Paraplegia, inability to move the lower limbs, and it will be numb. And you're going to be conscious. I am by the side of you. I will take care of you. You don't need to worry about anything. And you need to talk about all these things and develop a good rapport with the patient. If you do that, patient will cooperate nicely. Number 2, you position the patient yourself. Show the patient how to position her nicely. Flex and show nicely. This is what the position I want. And then tell her, relax now. I'm going to scrub and come back. Only when I ask you to get into this position, please get into this position. It will be very simple. It's a very small injection. You don't need to worry about it. And talk like that, position yourself. And lastly, the directional errors. This is a very important thing. Most of us, while doing a subarachnoid block, would have hit a bone naturally, right? Everyone would have done it. I don't think 100% of the times everybody goes into the subarachnoid space all the time. So you would have naturally hit a bone. What is the immediate response when you hit a bone? The moment we hit a bone, we remove the needle, comes out. The needle comes out. And we start looking here and there, either side, whether somebody has noticed it or not. We don't want anybody to see us fail in our dural puncture. The moment and when we fail, in a hurry, we go on poking here and there, and except the bullseye, we would have hit everywhere. Instead, mistake is the best teacher. Learn from your mistakes. When you hit a bone, stand by the side and see what is happening. There are 4 possibilities. You might have hit the bony structures. Which bone you have hit, depending on that, you need to alter. Now, how do you know that? For that, you would have probably hit the lower spine or the upper spine or to the two laminae on either side. These are the four bony structures all around. So you might be hitting one of these four structures only. Now, if you hit a bone, the first thing that you need to do is just manipulate the needle a little carefully, very gently and very little, and then go ahead again. Now, if you go ahead again, most of the times you will hit the subarachnoid space. Fine if you hit it, fine. But if you hit the needle, the bone again, now depend from the point of view of the depth of the needle hitting the bone. From the depth, what depth you hit the bone first time, and what depth you're hitting the bone second time. From that, you can gain a lot of information. There are three possibilities. You might be hitting the bone at a deeper level second time, at a superficial level second time, or at the same depth second time, right? These are the three possibilities. Now let's see each one by one, what happens. Supposing you hit the bone first time, manipulated carefully, and you hit the bone again at a deeper plane this time. That means that the possibility that you are hitting the lower spine is greater. You can see from the picture. If it is at a deeper plane, the possibility that you're hitting a lower spine is higher. Now then you need to manipulate it further carefully. If you point it further carefully, probably you will hit the subarachnoid space. Supposing you hit the bone first, manipulate it carefully, hit the bone second time at a more superficial plane. In that case, the possibility is that you're hitting the upper spine is greater. Now you need to deflect your needle corded. You deflect it corded, probably you will be successful. The third possibility is that you hit the bone first time, hit the bone again second time when you have deflected it carefully, and you're hitting the bone at the same depth. That means that you're hitting a flat structure. Which one is the flat structure around? It is the two laminae on either side. So that means that you're hitting the lamina this time. Now, if you are hitting the lamina, then you need to deflect it towards the midline. You don't know which way is the midline. Deflect it rightwards first. If you are successful, fine. Let it goes into the subarachnoid space. If not, try the leftwards. You will naturally succeed. So always don't erase your mistakes. Learn from them. Probably you will be successful. Learn from what you have made a mistake. Position of the patient. Supposing nothing works. You put the patient in the lateral position, you are trying, whatever manipulation you do, you are unsuccessful. Change the position of the patient. Maybe the anatomical, the position changes a little in such a way that it becomes advantageous for you. You will be successful. If it is from the sitting position, turn the patient lying down, lateral position, that might help you. So change of the position, change of the technique probably might help you. The third and the most important these days is the use of ultrasound. Ultrasound is very useful in many ways. It tells you the depth of the epidural and spinal space from the subarachnoid space, the position of the point of insertion of the needle, direction of the needle, in which direction you need to go. A lot of things, information it tells you. But one word of caution. Ultrasound, don't bring the ultrasound machine in when you are in trouble, first time. Learn earlier in simple cases. Try and put the probe. See what you require for a neuraxial ultrasound is a simple ultrasound machine with a curvilinear probe of low frequency, 2 to 5 megahertz frequency, which every gynecologist has in her clinic. When you go for a cesarean section, you bring the ultrasound machine, you get into a good contract with nice words with your gynecologist, bring the ultrasound machine, put the probe at the back and see before an elective cesarean section. Try and learn. And then this will become handy in a situation when you are in trouble. Supposing, okay, you have done all this, you got a good CSF flow, you have injected the drug, and there is no action at all. The second possibility is that there is total failure. The spinal does not act at all. Now, how to check the level of the block? Who checks it is the most important thing. And if you ask your surgeon to check the level of the block, it's a wrong thing. All the time, always you check the level of your block yourself and then ask your surgeon to proceed. How do you check it? There are different methods: motor power checking, pin prick, light touch, cold swab, of which pin prick, these days they are not using it because it is not good. If it has not acted, you're pricking a patient unnecessarily. Cold swab is not very efficient. So the checking the motor power and checking the light touch is probably the best way to check the level of anesthesia. Now, when to check is a very important thing. And how do you declare that it is a total failure? You have to wait for at least 20 minutes for the to allow complete spread of the local anesthetic in the subarachnoid space and act. Then only you can declare it as a total failure. So very early and too frequent checking will make the patient impatient. Patient will start feeling that my anesthesia has not worked, I am going to be in pain and such things. No, don't do that. Just comfort the patient. Tell her that everything is fine. This drug takes a little longer time to act. You don't need to worry. I am there with you. I will take care of you. Nicely counsel her. Give her confidence. Reassure her. And where to check is the next question. Now you see, the site of the phalansteal incision for cesarean section or a hysterectomy is the place where it is supplied by the lower thoracic nerves. Supposing if there is no analgesia at that point, it only means that up to the thoracic level, your block has not achieved. That's all. Does not mean that the lumbar is not blocked. Does not mean that the sacral area is blocked. With the heavy bupivacaine, with the heavy solutions that we normally use, heavy solutions, any solution, in the lumbar area, sacral sparing is not there at all. Practically, it is not there. Sacral sparing is there with segmental spinal when you use other drugs in the thoracic area. In the lower lumbar regions, when you use a heavy spinal, the segmental block at that too, the doses that we use is not a possibility. So the best thing is you must check in the sacral areas, that is either in the perineum or in the sole of the foot. So that is where you need to check the analgesia for. Life is like a camera, you see. You need to focus on what is important. Capture from good times, you'll get good pictures. Develop from your negatives, all your pitfalls, all your negatives, you develop from that. And if nothing works out, take another shot. You take a different picture. It will work out well. Subarachnoid like similar to life. You see, focus on the position of the patient, landmarks, direction of the needle, feel of the tissues, and all these things. Be prepared for difficult cases. Take time to perform. Use all your expertise. Learn from your mistakes. Improve every day. Still, if it fails, give another spinal. Very simple. So, in total failure, when you have declared it after 20 minutes, if you have declared that it is a total failure, the best thing to do is repeat spinal. When I say repeat spinal for a total failure, what is the dose that can be given? When it is a total failure, it obviously means that no drug has gone into the subarachnoid space. That means that you are not given the spinal at all. Now you can go ahead and give the full dose of the local anesthetic that you choose, that you are expected to choose for that particular patient, for that particular procedure. Okay, so if it's a total failure, when you have proved after 20 minutes that it is a total failure, then you can go ahead and repeat with the full dose. You can always give an epidural. You can you can do a CSE. CSE is always better because you have a backup epidural this time. If it fails again, you can always top up your epidural. So that's a better choice. Now, the third possibility is that there is a partial failure. Partial or a patchy block does not mean like this. Patchy here and there, you know, not just not like this at all. It follows a particular format. There could be an asymmetric block, there could be skipped segments, there could be unilateral block, or there could be inadequate pain relief. Asymmetric block is one in which the level of the block is higher than the other side. One side it is blocked nicely, the other side it is not covered. There could be skipped segments. Typically, some spinal segments have skipped. That is also a possibility in partial spinal. There could be a unilateral block. One side is nicely covered and the other side is completely left open. Now that is a third possibility. The last possibility is that the block quality is poor, that the pain penetrates and seen through the block. This is the fourth possibility. These are all the possibilities of a partial failure. Now, what are the causes of partial failure? Number one cause is the inadequate dosage. You have calculated, or I have calculated, a lower dose for that particular patient for that particular procedure. So for that level of the block, my calculation was wrong and I have given an inadequate dosage. That is the first cause. The second one is there is a possibility that you are not fixed the syringe properly to the hub of the needle, spinal needle, and some part of the drug is lost while injecting. That means that the sufficient quantities of the local anesthetic has not reached the subarachnoid space. Level of the dural puncture with respect to boricity. This is a very interesting area you need to see. When a patient is supine, you know that because of the lumbar lordosis, the highest point of the lumbar lordosis lies somewhere between L3 and L4, right? Now, supposing you have done a lumbar puncture above L3, that means either L23 or L12, and you have injected a hyperbaric solution, then the possibility is that the drug spreads upwards and a sufficient level of the block is achieved. Supposing you are injecting it at either L4-5 or L5S1, and then the heavy solution tends to spread preferentially towards the sacral trough, and the drug gets collected at the lower level. Now, that is again a reason why adequate level of the block may not have been achieved. The fourth possibility is considered to be what is called as dural sleeve. Now, this happens with the pencil point needles normally, with a side eye open. Now, what happens is, supposing you have done the puncture and the side port, the eye of the needle is just at the level of the dura, you try to aspirate the CSF. Because of the negative pressure, the dural sleeve moves towards you and the CSF, and the more of the eye opens into the subarachnoid space, and the CSF starts moving out. You get a good backflow. Whereas while you start injecting the drug, because of the positive pressure you're generating in the needle, the dural sleeve moves out, moves into the subarachnoid space, towards the subarachnoid space, opens the eye more into the epidural space rather than into the subarachnoid space, and most of the drug gets into the epidural space and the spinal has probably become partial. Now, this is one of the reasons quoted for partial spinal. Now, how to manage partial failure? Supposing you have detected this partial failure well before, so you have detected it that the level is going to be insufficient. Within about 15 to 20 minutes, you have recognized that the level is not adequate now. Then you can think of salvaging the block. You cannot, before the drug gets fixed, you can always think of salvaging your block. Now, how to salvage the block? Number one, don't be in a hurry. Give adequate time to act, at least 20 minutes. Counsel the patient, reassure, and tell her that you are with her and you are going to act well. Number two is you can facilitate the spread of the local anesthetic in the subarachnoid space by some of the means. Now I'll talk about it now. Now, normally what we do when we feel that the level of the block is inadequate, what we normally do, we give a head down tilt, right? Let's see whether the head down tilt works. So this is the spine, the lateral view of the spine in this supine position. Okay. Now you have given a spinal anesthetic and the drug has remained in the sacral trough, most of it. That's why you have not got the adequate level of the block. Now you want to make the spread better. So you will give a head down tilt, right? You give a 5-degree head down tilt. If you give a head down tilt, the drug, which is heavy solution, cannot climb on the lumbar lordosis and come above. You give a head down, 10-degree head down tilt. Even then it cannot. So you give an extreme head down tilt, then there is a possibility that the drug ascends nicely. And then there is a possibility that a little later, you can risk the possibility of a high spinal block because you are giving an extreme Trendelenburg tilt. Let us see in a different position. You put the patient in the lateral position. When you put the patient in the lateral position, the spine becomes flat. Now you see the lumbar lordosis in the horizontal plane. Now that curvature is lost in the lateral plane, in the horizontal plane. When that happens, you see, in the lateral position, you give a head down tilt, just a 5-degree head down tilt, the drug nicely ascends up. The drug comes into the thoracic region. Now you turn the patient supine, it spreads nicely. Okay. So if you want to give a head down tilt, give a slight lateral tilt and then give a head down tilt. That will make the facilitation of the spread of the local anesthetic. There's one more method by which you can do this. So you see, this is how the relation of the spine to the pelvis here. Now, if you flex the hip, when you flex the hip bone rotates, you see, when the hip bone rotates, it nullifies the lumbar lordosis to a certain extent. The spine becomes a little flat. I don't say that the lumbar lordosis is completely lost, but the spine becomes more flatter than in the supine position. Now at this position, in the flexed hip position, you give a slight head down tilt, the drug nicely ascends. Now this is a possibility. One, you can give either a lateral position or you can flex the hip and then give a slight head down tilt. That will facilitate the spread of the local anesthetic. If you give an extreme head down tilt, you are risking a high spine. The third maneuver is a Valsalva maneuver. You ask the patient to do a Valsalva. Everyone knows how to teach the patient to do a Valsalva maneuver. And when you do a Valsalva maneuver, the thoracic pressure as well as the intra-abdominal pressure rises. These two, the intra-abdominal and intrathoracic pressure rising, will increase the intra-epidural pressure, which will compress the dura mater, make the CSF pressure higher, and make the CSF spread. Now, this will increase the spread of the local anesthetic. Supposing it is a CSE tech, after giving a spinal, you're placed an epidural catheter. In that case, what you can do is, you can distend the epidural space with normal saline. When you do that, the distended epidural space pushes the dura inside, and then this CSF is displaced on either side, and this will also facilitate the spread of the local anesthetic. Now, this is what is known as the epidural volume extension. And this is a very interesting technique, and many people do this, and it is very, very useful. Your spinal action becomes better if you distend the epidural space with normal saline only. Now, systemic adjuvants can always be used. Systemic sedation, any one of the sedation that you are using, Entonox, or even local infiltration can also be tried. All these with a pinch of salt. You need to be very, very careful about it. You can always do it. Local infiltration, of course, definitely helps. Now, after 20 minutes, if you have an insufficient level of the block, you can repeat a spinal. Now, here is a tricky situation. You see, in a partially acting spinal, to repeat a spinal is a tricky situation because you never know how much of the drug has gone into the subarachnoid space earlier and how much I can afford to give. How much is too much and how much is too little, you never know. Now, what is the possibility of high or total spinal, or what is the possibility of a low spinal, even an still an inadequate block, even after the second injection? Now, this you need to learn from your practice. Supposing the textbooks give a standardization. Supposing if the block is only lumbar, that means that it has not reached the thoracic levels at all, that it is only in the lower limbs. In that case, if the level is below the level of L1, you can give about 60 to 70% of the original calculated dose. For a cesarean section, I'll give you only one example. For a cesarean section, up to about 7.5 milligrams of bupivacaine heavy is safe. You can give, if it is only lumbar region block, you want to repeat a spinal, for a cesarean section, you can give about 6 to 7.5 milligrams in the second attempt. Now, repeating spinal, when I say repeat spinal, how many times you can repeat spinal? I'm sure there is in the audience, there will be at least half a dozen people who would have given the spinal at least twice, thrice, even 4 times people might have given. But there is an officially only once you can repeat. Because the literature support, if you land in trouble, literature support is there for repeating the spinal once. If you repeat it twice or more than that, then if you land in trouble, you may not get a good support. So repeat spinal only once. Now, what are your concerns? We all know that there is insufficient level of the block. High spinal, total spinal is a possibility because a lot of drug you might have given. Cauda-equina syndrome, you know that heavy local anesthetics tend to get accumulated, and there is a possibility that it may get into problem. You may get into problem. PDPH is possible because repeat spinals, repeat punctures of the dura is a possibility. Infection, because many times you're entering into the subarachnoid space, so the possibility of infection. All these are concerns. You need to be careful in minimizing any one of these problems. So if there is a patchy block, an inadequate level of the block, after 20 minutes, of course, epidural is a possibility, as I told you earlier itself. Systemic sedation, Entonox is all a possibility, but a bit of this and a bit of that is a recipe for disaster. So give midazolam first, fentanyl next, morphine next, some other analgesics, and then you give oxygen, nitrous oxide, then you start giving general anesthesia. You may land up in trouble. Never over-sedate a patient without securing the airway, at least with an LMA. If you tend to over-sedate, you will land in trouble. You might land in trouble. If nothing works, you know, there is always a general anesthesia. Why is this called a mask? Anybody has any answer for this? Because it masks all our deficiencies, you see. Spinal fails, mask it. Epidural fails, mask it. Block fails, mask it. So that is why it is called mask. You hold a mask and mask all your deficiencies. So general anesthesia is the last choice, and it is a definite choice for all these situations. So after, the next possibility is after skin incision, first thing that you need to do is stop surgery because the patient is in agony. Your purpose is to keep the patient comfortable. You are an anesthesiologist. You must make your patient comfortable. That is your primary necessity. So stop the surgery. Request the surgeon to keep the scalpel back and hold his hands and fold his hands and stand by the side. Now you start managing. Tell the patient that you are with her, with him. You are going to manage. Your pain is going to go down in a short period of time. Reassure the patient. Tell her, if the pain is only a pressure type of symptoms, pressure type of pain, in that case, you can facilitate the block. Wait for some time, local anesthetic infiltration, sedation, all the salvage techniques of salvaging the block I told you earlier, all of them can be used. General anesthesia is the last choice. Supposing if the pain is sharp pain, then there is no choice for you. Go ahead and induce general anesthesia. Don't think of anything else. You can't repeat a spinal after the skin incision has been made. So have a low threshold to conversion into general anesthesia if the patient is in pain after skin incision. So you have various avenues to manage. Why general anesthesia is the first choice? Take it as the last choice. So this is the take-home message and how you manage each and every one of these situations. Thank you very much. Thank you for the patient hearing.
Thank you very much, sir.
Excellent
Excellent,
lecture, sir. Really, I am amazed. And this is the best lecture that I have heard on this topic.
Thank you very much.
Yes, we will have comments from our chairpersons.
It was really wonderful listening to you, sir, because I just cannot mention in words. I heard this lecture second time, but it is really amazing, sir. Really
Thank
amazing.
you very much, madam. Thanks a lot. Thanks a lot.
Sadhna madam, please.
It was a really very informative lecture for all of us.
Thank you, ma'am.
And I should congratulate him for emphasizing never oversedate the patient. And second is wait for 20 minutes before repeating spinal. Many times we repeat spinal before
Thank you,
that and high spinal occurs. And most of the time, the second person is junior resident
Thank you.
and nobody else is available and high spinal leads to calamities. I think he has very
Yes,
well impressed these points. One more point I wanted to stress was when we are giving GA after partial spinal, we should be very careful because there can be severe hypotension after induction. And I have
Thank
seen
you so much, ma'am.
Yeah, lives were lost because of that one. So very excellent lecture, sir. Thank you so much.
Thank you very much, ma'am. Thanks a lot.
Thank you,
One
madam.
more thing, is there any reference for snake bite and failure of spinal? I have read about scorpion bite, but snake bite I am not aware of that.
No, madam. Snake bite, I don't know about. Scorpion bite. Scorpion
Yes.
bite, yes.
Yes. So because
Did I say snake bite earlier?
I think so.
No.
No.
Scorpion bite.
Oh,
But-
extremely sorry, madam. If I have told snake bite,
No.
I withdraw that. It is because it is in scorpion bite.
Scorpion bite only.
No, you said scorpion bite.
My
only.
apologies.
Yes.
My
And
I think I must have heard wrong.
no.
It might be possible.
yeah.
I just
Anyway,
Now they said you add additives in the spinal. There will be a good action even in scorpion bite patient. If you add
Yeah.
additives,
Yes. Yes,
Yes.
that's true.
I don't know about the references for that, sir. See, in scorpion bite, there will be a pure local anesthetic resistance. Local anesthetic resistance. Maybe most of these additives which act by different mechanisms probably act better than the local anesthetics.
Can I raise one point?
Yes, sir.
Yes, sir.
Yes, sir, please.
See, this business of waiting for 20 minutes before reaching a verdict, success or failure, is all right if the situation allows you. Invariably, we are in such a rush in obstetric conditions, 20 minutes waiting, 20 minutes, the cesarean should be over sometimes. So I
Sir,
don't
you're
think
right.
sort of in every case you can wait for 20 minutes, only if the clinical condition of the mother and baby allows you to wait for 20 minutes. Otherwise, some other
Sir, I
remedial
agree with
measure
you.
by which
The
the
point
baby
is-
can be delivered should be adopted.
Yes, sir, I agree with you.
Huh? Yeah.
I agree with you totally. But the point is that if you want to repeat a spinal, you need to wait for 20 minutes. Supposing you can't wait at all, that it is an emergency cesarean section, the spinal has not acted well instantaneously. I told you earlier, your mask is there. Always, you can always mask your deficiencies.
Yeah.
But To repeat a spinal, to say that it is a total failed spinal, you need to wait for 20 minutes.
Second thing is, don't allow the obstetrician to start unless and until you have used all avenues to make sure, and there are many other ways of making out whether sort of the spinal is acted or not acted. The simple thing like, let us say if the Foley's catheter is passed after the spinal is given. So you watch the patient's reaction to the introduction of Foley's catheter. You see the BP dropping. Okay, you see the facial expression of the patient after the spinal is given, and all these evidences will 90% of the time tell you whether your spinal is acted or not. But this business of the painting is done, the draping is done, and then the gynecologist sort of takes a forceps and gives pinches here and there is totally wrong. That should never be allowed only.
Yes.
Yeah,
Thank you, sir.
Become a
Thank you.
reflex action that he pinches the skin and then starts. By the time a painting and draping is done, you have made sure that your spinal is acting.
Yes, sir. We absolutely agree.
Yes, sir.
with you.
Yes,
Thank
sir.
you.
Yes, sir.
Yeah. Agrawal madam, we want your expert opinion. Madam, unmute. kya?
Madam, please unmute. Madam, unmute.
Madam, we can't hear
Can't
you.
hear, madam.
Mute, unmute परत एकदा करा मॅडम. Yeah. Yes.
If scorpion bite is there, why should affect only spinal nerves? Because I had done surgeries under brachial block and it was working well. So I'm not yet sure whether the scorpion bite really affects the spinal anesthesia.
Madam, previous history of scorpion bite does not produce local anesthetic resistance in all patients. It is only the incidence of local anesthetic resistance is high in previous history of scorpion bite. It was a retrospective study, madam,
Okay.
that all those patients in whom the local anesthetic resistance was there, like either block or spinal or epidural has failed, they went ahead and checked the previous history, and there was a history of scorpion bite. That is all. It does not mean that every case of scorpion bite there will be local anesthetic resistance.
Okay. Thank you, sir.
Thank you,
Madam,
ma'am.
Agrawal madam.
Yes, sir. I wanted to. Yes, sir.
Madam, lot of
Hello,
discussion.
sir.
Ma'am.
Okay.
Yes.
ma'am.
I wanted to ask, sir, that nowadays many anesthesiologists are going for the segmental spinal.
Yes, ma'am.
So whether that is increasing the failure rate?
See, segmental spinal. See, I was not talking about the segmental spinal in this case at all.
Yeah.
See, segmental spinal is a separate entity altogether. For specific surgical procedures, with specific procedures, you do a segmental spinal. Of course, segmental spinal, the possibility of failures are more because you are giving very small drug, your small amount of drug, your height of the block, where you do the DP, all these things matter to a very great extent. But I'm talking about the standard spinal anesthetic technique with a heavy local anesthetic, heavy preparations. This is see what we are practicing most of the time. More than 99.9% of the spinals are regular spinals with heavy bupivacaine, lumbar puncture. It is true. Now, in that, if there is a failure, what and how to go about and manage. This is the practical talk, which even the residents to the senior consultants, everybody faces day in and day out. Now, just to see how best we can manage, how best we can analyze and formulate some of the guidelines for this. That was how the topic was taken.
Yes.
Not in segments spinal at all.
Yes, of course, it is a very excellent for the PG students and practicing anesthesiologists and all the people, teachers. It's very excellent, sir.
Thank you, ma'am.
Thank you, sir.
Thanks a lot, ma'am.
Sir,
One more-
what about the cycling
One more
movement?
suggestion that I would like to give is that in every teaching hospital, for the sake of the students, we should have lumbar vertebra ready so that when the spinal fails, and as sort of was pointed out in the lecture, you can hit the upper spine, you can hit the lower spine, you can hit one of the laminae. This can be demonstrated with the help of the lumbar vertebra. Okay, which should always
you,
be
sir.
readily available. What happens is the student fails. He doesn't know at the end of it why he failed. What they do is असं तरी needle आत जायला पाहिजे. And then
Perfect, sir.
CSF is जवळपास तिकडेच कुठेतरी आहे, you know. So if he gets it, he's happy. If he doesn't get it, he thinks he's failed. But he does not improve. He does not improve.
Yes, sir.
Very true, sir.
So every time,
Very true, sir.
if more or less it is pointed out to him that this is the mistake you made, and if he rectifies his mistake, he will take lesser time to become good at it.
Yeah, yeah.
So in teaching,
Excellent, sir.
lumbar vertebra must be there.
Yes, sir. Yes.
Yes, sir.
I think
Point
we'll
well
have
taken, sir.
discussion, sir. Yes, sir.
Yes, sir.
We'll have discussion again at the end of the session. Let's move on to the second topic. There are
Okay.
many questions in the chat box, in fact. So we will go
Yes,
on
sir.
for the second topic, ma'am.
Thank you, sir.
Dr. Rajesh Rao, please share your screen.
Screen.
Can I start the presentation?
Yeah, please, sir.
Yes,
My
sir.
screen is visible, right?
Yes, sir.
So, first of all, let me thank ISM Maharashtra for giving me this opportunity, especially Dr. Manisha Katikar, madam. And more so, it's an honor to share this platform with great stalwarts and with huge academic background. I've been in private practice for last more than 30 years. So whatever I'm going to speak today would be from my personal practical experience in private practice. This is the usual disclaimer I put up before any presentation. So what is continuous spinal anesthesia? It is producing and maintaining spinal anesthesia with small doses of local anesthetic injected intermittently into the subarachnoid space via an indwelling catheter. It is targeted delivery of the drug directly into the cerebrospinal fluid. Now, in the next about 20 minutes, I will be going through the brief history, current practices and gadgets, complications, and take-home messages. The history of continuous spinal anesthesia is as old as the first spinal anesthesia. Like Dr. Ravindra said, it's about 120 years back. First continuous spinal anesthesia was tried in 1907 by Dean. Then subsequently, over the period of time, many people did it in different ways. Then there was some complications which arose. So there was a gap of some years. So in 1906, Henry Dean, and then 1940, William T. Lemon, he had some cases which he presented where they used the needle in situ process. This is also called as fractional spinal anesthesia. It is an underutilized technique in modern anesthesia and allows small incremental dosing of local anesthetic for an indefinite period of time. So what are the advantages of continuous spinal anesthesia? First, it avoids invasive airway management, provides good abdominal wall relaxation. It enhances intraop analgesia. The block action is rapid, good hemodynamic stability. The doses of local anesthetic required is very less. You can go for block prolongation. It is safe and easy to use under close monitoring. It also allows post-op analgesia maintenance with high efficiency and minimal effect on mental status, reduction in major post-operative complications compared to general anesthesia. So why not just routine spinal or an epidural or combined spinal epidural? The advantages of combined spinal, continuous spinal anesthesia is it is reliable, it is predictable, it It offers superior muscle relaxation, controlled dosing as per requirement. There are minimal hemodynamic variations, and it is comparatively cheaper. Now, if you consider a position, especially in the scenario of obstetric analgesia or anesthesia, everybody must have had an episode and faced this accidental dural puncture. So, how would you go about it? If there is an accidental dural puncture, you have two options: either to resite the epidural catheter, or you can just go ahead and place an intrathecal catheter. So, if there have already been multiple attempts, there is difficulty to position the patient is in severe pain, or she is nearing delivery, and there is non-reassuring fetal tracing, I think it's better to place an intrathecal catheter. And if all these are no, then you can very well go ahead and place an epidural catheter. In single shot spinal anesthesia, we require large volume of local anesthetic. The duration is finite and unpredictable, and there are greater hemodynamic fluctuations. In epidural anesthesia, you require higher volumes. There is sparing, less motor effect, and so less relaxation will be there, and suboptimal sacral root draw. When can you consider continuous spinal anesthesia? It can be used for surgical anesthesia, post-operative or labor analgesia, or even for chronic pain relief. Slow titration of sensory level with small incremental boluses allows the patient and the operator adjustment to sympathetic blockade. Possible decreased rate of catheter failures compared to epidural placement. Probable modest decrease in PDPH rate compared to non-obese parturients. High rate of epidural block failure up to 40% makes continuous spinal anesthesia an attractive alternative. Now, this is a picture to show the accidental dural puncture. So, what can you do? Make another attempt, convert to spinal anesthesia, or abandon the procedure. There is almost 1.8 to 3.6% incidence of accidental dural puncture. This is a chart to show the concentration of drug which you can use for analgesia and surgical anesthesia. Preservative-free duct should be used for spinal injections. You have to consider that the dead space of the epidural catheter and the filter, which is about 1 to 1.2 ml. Another advantage of continuous spinal anesthesia is the ability to titrate. You can avoid general anesthesia and minimize sympathectomy. It is easy to perform. Previous back surgeries where epidural is contraindicated, long lower limb surgeries, patient with comorbidities, cardiac diseases, is a better option. Continuous spinal anesthesia allows incremental dosing of local anesthetic. There is a predictable titration of block to an appropriate level with better hemodynamic stability than a single shot spinal. It is useful in controlling arterial blood pressure in patients with severe aortic stenosis or pregnant women with complex cardiac diseases. It serves as an alternative to combined spinal and epidural technique. And in laparotomies where general anesthesia may be too great a risk. For abdominal surgery, general anesthesia is definitely the default technique. Single shot spinal anesthesia has got its own reservations. There is regression, inadequate muscle relaxation at the end of the surgery. So with continuous spinal anesthesia, we have cardiac stability. We are using low doses. The chances of local anesthesia systemic toxicities reduces. There is sustained surgical anesthesia for prolonged periods. Perioperative analgesia, low doses, it is similar to gold standard epidural. So loading dose would be about 1 ml of local. We have many local anesthetic available now. Initially, we were using only bupivacaine. Now this ropivacaine and isobaric, duoanavine has come in market. What are the available sets for continuous spinal anesthesia? There are two types of sets. One is a catheter over the needle set by B. Brown, which are called spinocats, and the Seldinger technique 5 catheters. This is a cross section showing the catheter through needle and the needle to catheter. Now, the issues with small gauge catheters is it is difficult to manipulate. There is little higher resistance to the injection. Failure rates are high. Oda-Equina syndrome was supposed to be associated with microcatheters due to trauma or chemical toxicity, excessive accumulation of local anesthetic drug. Caudal direction of the catheter associates with higher failure rate and local anesthetic cooling. Now, there are conflicting data to show that intrathecal catheters more than 24 hours reduces PDPA. Due to these spinocats are not very easily available, so I have been using the standard epidural kit 18 gauge, though pediatric epidural kits can also be used. Certain tips for continuous spinal anesthesia: be gentle in advancing the catheter into the subarachnoid space. Use the gravity test to confirm the tip is in the correct subarachnoid plane. Isobaric bupivacaine can be used to avoid cephalad spread of the drug. And you have to be very sure and make everybody know that it is a spinal catheter and not an epidural catheter. Prefer a familiar equipment with low number of technical steps. Avoid too small gauge catheter. We can introduce up to 4 to 5 centimeter cephalic catheter can be introduced. The CSF, the air from the catheter or the filter can be done by aspirating the CSF or priming the catheter with local anesthetic solution. Small syringes like insulin syringes can be used for dosing. Catheter and the filter dead space is about 1 to 1.5 ml. For PDPH prevention, you can leave the catheter behind for 24 hours or inject saline before removing the catheter. This is a small video to show that how to introduce the epidural needle and the catheter. The moment you enter the subarachnoid space, you will get a CSF flow. Then insert the catheter.
Yeah, you can do it low.
Which drug can be used for continuous spinal anesthesia? Any drug which has safely been used for routine spinal can be used. Any additive which has safely been used can be used. Isobaric local anesthetic versus hyperbaric local anesthetic. Choose judiciously as per the case requirement. You can start with very low volume, which can be easily titrated. And remember to consider the dead space volume of the epidural catheter and filter. What are the advantages of isobaric local anesthetic? It is not position dependent for intrathecal spread. Hence, can be utilized with good results in surgeries, requiring patient to be positioned laterally or prone immediately without affecting the local anesthesia spread. It has remarkable cardiovascular stability even with high level of blocks. Low dose blocks sensory more than motor, giving selective segmental spinal. Onset is gradual. It preserves the muscle tone and power, and recovery of muscle motor loss is faster, hence useful in early mobilization. There is less sympathetic blockade, less chance of DVT and early bladder control. Well, there are complications. Nothing is without complications. It is most of them are same as for routine spinal anesthesia, like infection, hematoma, or neurological. Koda-Equina syndrome, which was noted much earlier in practice, is not reported in recent times. The most expected is PDPH, which can be minimized. These are certain statistics showing different incidents of post-pleural puncture headache and the failure of continuous spinal anesthesia. Koda-Equina cases more seen with when 5% lignocaine hyperbaric was used, and there have been complications of microcatheters also, like cannot thread failure or the catheter breaking. Koda-Equina syndrome, Rigler et al. In 1991 had 4 cases. He attributed it to microcatheters, which brought about the FDA ban for a few years, and so the 5% lignocaine which was used. Arkush et al. And Lux in 2008 and 12 came out with studies which did not show any significant Koda-Equina syndrome. Regarding PDPH, microcatheters came. Curley et al. In 1990 used a 32 gauge catheter passing through a 26 gauge spinal needle. Post-pleural puncture headache, can it be minimized? To a certain extent, in my practice, I've been keeping the catheter for about 24 hours by knotting it and labeling it with as a spinal catheter to avoid accidental injections, and removing after 24 hours. No significant case of PDPH were seen. So the take-home messages is there should be proper patient selection, proper counseling, quantification of the expected time of surgery, surgeon acceptance, availability of all basic monitoring equipment and proper anesthesia workstation. Patient who are unwilling to go undergo general anesthesia or are at high risk of perioperative morbidity or mortality with GA. Older patients who are low in physiological reserves with multiple comorbidities, in whom general anesthesia will invite polypharmacy, cognitive dysfunction, and other complications. Continuous spinal anesthesia should not be an option to cover non-availability of basic monitoring requirements or as a cost-cutting procedure. These are a few literature reviews supporting intrathecal catheter placements, and the comparison between spinal continuous and spinal anesthesia or epidural. There are a lot of literature available on the net. This was a short presentation. Thank you very much, and wish everybody a happy Diwali and of course Christmas New Year to come. Thank you very much.
Thank you very much, sir. We'll hear from the expert now.
Yes, sir.
Sadhana Kulkarni, madam, your comments.
Nice presentation, sir. And I think it was a relatively new topic for all of us. And particularly, I myself have not used this continuous spinal. I had no opportunity to use it. I only wanted to have 2 suggestions that I think in morbidly obese patient, this can be a good indication for giving continuous spinal. And second was to reduce PDPH, can we inject 10 ml of saline before removing the catheter?
Yeah, that is one more thing which is been prescribed for this. I have done in a couple of cases, but the thing is now I've started knotting the catheter, so I cannot inject while removing.
Okay.
I knot the catheter, so there is no, you cannot inject further after that.
So
Sir,
what is
are
the
there-
medico-legal implication of this? If something happens, is there any reference in textbook?
Sir,
Because in court, textbook references are only used.
I don't think, as madam has said, I don't think it is come in textbook, but I think in morbid patients, you can very well justify it by giving it. There are too many articles are there in the, even in journals.
Whether court will accept that articles.
If you can justify that risk-benefit ratio, definitely yes.
is in the court, if the reference is there in two peer-reviewed journals, I think
Yes.
the court definitely accepts it. And
Can I say
second
something?
is, sir, how that knotting is done? Can you please
Madam, sir,
detail us?
म्हणू नका. Sir, म्हणू नका.
Can I say something?
Yeah.
Sir, please.
Hello. It is
sir,
given
please.
in Miller's as one of the best anesthesia for cases, very morbid ill patients and severe cardiac diseases, like for PPCM,
Yes.
severe aortic stenosis, and other things. There are many references, even in standard textbooks.
Yes, yes. Dr. Paliwal is a big proponent of
Segmental
spinal and segmental spinal.
Yes.
Recently, I had the opportunity of talking on segmental spinal at one of the municipal hospitals in Mumbai.
Sir, how
Sir,
that
can-
knotting is done? Can you just detail us?
Madam, just you tie a knot, double knot on the catheter near the filter. So you cannot inject from that. So for safety purpose, nothing else.
Okay.
Sir, can you give me a standard protocol of the dosage schedules and the top-up dosage for a particular procedure?
Yeah.
Which you have used?
Yeah. Mostly, I have.
For
used
example,
this-
maybe you
Yeah,
take
I
one
use
example
this-
and then give.
Yeah, I have used this mostly in orthopedic cases, hip fractures, where we used to give in high-risk patient used to give paravertebral with sciatic blocks and all those where large volume was required. So now with indwelling and intrathecal catheter, we can start by just 0.5 ml of a hyperbaric solution and titrate it. Maybe repeat it after 15 minutes, another 0.5 ml. So with 1 to 1.5 ml, without much hemodynamic variations, we are getting excellent results. So we can go down on the dose.
Supposing
instead
if
of
the
single
surgery
shot.
gets prolonged,
Yeah, we can just keep on continuing. I attach the syringe to the filter, so there is no chances lessened. Contamination chances are lessened. So just give incremental doses as and when required.
Suppose it is a lateral position surgery.
Yeah, I would use an isobaric preparation.
Yeah, you can use hypobaric also.
Yeah.
thank you. Thank you so much, sir.
Thank you. Thank you.
And this is not for abdominal surgeries.
So you can definitely, yes, madam.
But if we
We
block
place the catheter little higher up. I keep around 2 to 3 centimeter catheter cephaloid. So you can just very good for abdominal surgeries also. I have done in abdominal surgeries also.
Okay, because if
I
the
have done segmental spinal with segmental continuous spinal also.
Okay, this is not a continuous routine spinal for abdominal surgeries, because if the sympathetics are blocked at that level, then hypotension will occur.
Yeah, but then that's what with titrated doses, like in single shot spinal, we will have to give 3 to 3.5 ml straight.
Yeah.
Plus unpredictable action, regression of the action. So here we can control the level by giving incremental small doses as required.
Thank you, sir.
Sir, how much is the PDPH incidence in your cases?
I have not measured, but surgeons are very particular nowadays. They keep telling you, even with final, next 2-3 days later, 5 days later also they'll call up, sir, त्यांना डोकं दुखतंय, त्याचं spinal मुळे असेल का? But luckily in this continuous spinal, maybe 2 to 300.
Okay, sir.
2% to 3%.
Agrawal
Okay.
madam,
Yes,
please.
Agrawal madam.
Yeah.
Okay,
Sir,
please.
just the excellent technique, sir. I think that is very useful in an orthopedic patient where patient comes at the age of 90. Recently, I given anesthesia for 93 years patient. In such a cases from the fracture, lower limb surgery, when we give a spinal, if you go with the low dose, we are always worried whether level will be adequate or duration will be adequate or not. And we cannot give too much dose. That is what we give in our young patients. So here with the continuous spinal, we can give a titrated doses where we can avoid the hypertension. So I think it's very important technique, sir. The second important thing I would like to ask, sir, you said for the abdominal surgery also we can go with the continuous spinal. What about the relaxation? Because like in a abdominal hysterectomy, surgeon needs a good relaxation. And here we give a titrated doses with continuous spinal. So whether there is adequate muscle relaxation, is there abdominal muscle relaxation?
That is what, madam. You can titrate your dose as per the relaxation. You can go add a 0.5 ml more. You can add additives to it. And as you said, in very morbid orthopedic patients, we used to give maybe a predominantly unilateral spinal or blocks. But blocks are high volume blocks.
Yes, of course.
Even in blocks, we have seen hypotension and hemodynamic stability. Chances of local anesthesia systemic toxicity is very much high. Plus the other limb we have to take care of. So with this technique, I think all these things are minimized.
Definitely, sir.
There is one point I would like to raise about the relaxation. See, segmental spinals or segmental epidurals will not give you very good relaxation, whichever the area of surgery. Right from the insertion and the origin of the muscle, if both are not paralyzed, you will not get good relaxation. I give you an example of a McBurney's incision for appendicectomy. One probably feels that if you give a segmental spinal covering that area of the McBurney's incision, you will get relaxation. But unless the relaxation, even for a McBurney's incision, goes up to T6 to T4, you will not get very good relaxation to get the appendix out of a small McBurney. So in case of these continuous spinals, if you try to minimize on the dose, I think there will be a sacrifice of relaxation rather than a larger dose at the cost of fall of blood pressure and cardiac output.
You can always keep on increasing the dose. We start with a small dose, but we have that in control in our hand. So you can always increase the dose to maybe 1.5 as required for the adequate relaxation and analgesia.
You're right there.
Now, sir, I have a question. The epidural catheters, when we are using for intrathecal use, how safe we are medico-legally?
Again, the same question is medico-legal.
Question was raised. Sadhana madam already given the answer.
Even with micro catheters, there were a lot of complications which happened. Maybe cauda equina was there with micro catheters. Micro catheter breakage was there.
And
failures were quite high.
Injection pressure is very high, in fact.
Yes, there is a hand.
It is a
Dr.
recommended
Pratibha.
technique, actually.
Yes, yes, sir.
Dr. Pratibha raised
Yes.
his hand. Her hand. Dr. Pratibha, madam.
Yes, yes, sir.
Please
Can you hear me?
ask your
Please
question.
ask your question, ma'am.
Rao sir, good evening, sir.
Good evening.
Sir, how much saline you used to give to avoid PDPH before you started knotting?
Couple of cases only I have given.
But what was the
10,
volume
10,
approx?
8 to 10 ml. 8 to 10 ml.
Okay. And can you predict which patient might get PDPH during your procedure?
I hope all of us could predict that.
No, matlab, during your procedures, whether you could judge like if this has happened, this patient has a chance of getting PDPH.
No,
And sir, what was the maximum surgical time you have used this thing, continuous spinal?
Maximum surgical time was about 4.5 hours.
Okay. And so you have used combination of drugs like what we use xylocaine with bupivacaine. So in this also you have used combination?
No, I have used combination of isobaric and hyperbaric, not two different drugs.
Okay, okay, of the same.
And I've used additives.
Have you used any hypobaric solution for surgery in lateral position for subsequent second dose?
Isobaric use केले sir. Hypobaric नहीं.
Hypobaric नहीं.
Dr. Paliwal has
Suppose
done
a patient is hypobaric solution for lateral position surgery of limb surgery. If you use hypobaric solution, that will be a good action
Yes.
in the operated limb.
Yes, yes. But even isobaric works well.
Okay.
Sir, about the knotting of catheter, I want to make it clear why. What is the purpose of knotting? Just to prevent the accidental injection by staff.
Yes, that's it.
I have
Specifically,
n number of examples where in spite of labeling my epidural infusion, it has been started IV.
Yes, sir. Even I have, and that too at corporate hospitals.
Yeah.
Big
Yes.
hospitals.
So, to be on the safer side, that is the best thing to do.
But sir, after knotting, that means you don't plan to use the catheter.
No.
Because once
No.
you knot, then you can't unknot.
Finish. After the surgery, the job is done.
Then why you want to keep the catheter, sir?
To reduce the chance of PDPH.
Okay.
What happens is if you keep it
At
for
what level you
24 hours,
not it, sir?
you remove it. So anywhere from there to the tip of the as near as to the filter as possible.
Yeah, because if we want to use it, then we can cut it at the lower level and again can we
I
use
would
it
not, sir. Contamination, infection.
Correct.
with gloves and all that thing?
No, sir, I don't think so. We should cut the catheter.
Yes. Okay. Sir, how to proceed if there is a accidental puncture of dura and we have to give a continuous spinal anesthesia?
That one slide I had mentioned, all of us must have faced accidental dural puncture.
Yeah.
Yes.
It's very common.
Yeah.
So we have 2-3 options in that, either to replace the epidural catheter or just insert the catheter intrathecally and use it as continuous spinal.
Okay. Okay.
The
sir.
same needle, once you get the flow, just close it with your thumb and put the catheter inside the intrathecal space and come out.
Shall I answer this question as an obstetric anesthesiologist?
Yes, sir.
Okay, sir.
Yes, sir. Yes, sir. Please.
See, if we have an accidental dural puncture while placing an epidural catheter for labor analgesia, in that case, I have threaded the catheter, the epidural catheter intrathecally, and maintained this as a continuous
Analgesia.
spinal analgesia. Yes, the dosage and the
slide has mentioned that, sir.
Yes,
If
yes.
you already had multiple punctures, the patient is not
Yes.
cooperative, she is in
You're right.
late labor or there are fetal decelerations, then you can't take a
Yes.
chance of placing another catheter.
Yes. So what
Yes,
we
sir.
normally do, what we use is the same concentration, the same mixture of the local anesthetic, the 0.0625% bupivacaine with 2 mics per cc of fentanyl. We usually give about 10 to 15 ml every top of dose every 1.5 hours epidurally, whereas for with a continuous spinal catheter, we give about 2 to 3 ml only. The same low concentration local
Absolutely.
anesthetic with
Yes, sir.
2 mics per cc of fentanyl. I've,
Yes,
of course, my experience with a continuous catheter in orthopedics and all is very little. I have used it only once, so I cannot talk about that. But obstetrics, I have used it many times, and it is pretty useful.
And
But
most
the
important thing is you
PDPH incidence increases.
Yes.
the solution has to be preservative free. That is
Yes,
most important.
yes. Because
Yes.
safe solution you
Yes.
can't use. Yes.
Yes, yes.
Yes.
Can I ask?
Yes, sir. My question to the Ravindra sir.
Hello.
Can we have manipulation like cycling movements to increase the level of spinal anesthesia towards higher side?
No, I
Is
didn't
it
get your
worse?
point. Cycling
Yeah,
means
it were cycling movements of the legs.
I don't know, sir. I have no
Many
experience
times
in
they
that.
do cycling movements of the leg So the
Yes.
drugs go upward.
Possible, sir. I don't know. I don't know about it. So I cannot
Even
answer
if
that
you ask
Okay.
patient to cough,
Yes.
Yeah,
take
that is
cough,
another.
Yes.
that is
Possible,
Doctor-
because this also,
Yes.
flexion of the hip repeatedly, flexion
Yes.
extension of the hip repeatedly, probably that will also help.
That cycling movement
Dr.
also.
Ravindra, you mentioned 10 to 12 ml for labor analgesia. Isn't it too much?
10 to 12 ml epidurally we use, sir.
Epidurally.
Whereas if it is for continuous spinal, we use 2 to 3 ml only.
2 to 3 ml per hour. Or what are the top-ups you give?
Every
If you
90
want
minutes we
to-
usually, sir, the labor analgesia requirement is a little less than the regular analgesics.
There
So
are
2 to 3 ml of
parts.
point.
There are two
Shall I-
parts. Either it can be as a continuous this thing
Infusion.
infusion, or it can
Or-
be intermittent boluses.
Yes, sir. Yes, sir.
For continuous infusion, it is 2 ml per hour. For
2 to 3
intermittent
ml per hour.
boluses,
For intermittent boluses also it is 2 to 3 ml every bolus.
it is actually 1 to 2 ml every 15 minutes, maximum of 3 boluses per hour, and 2 micrograms per ml of fentanyl, which is added to it.
Sir,
It is
I
maximum
give
3
it,
boluses in an hour, and
sir,
one.
I always give it every hourly.
You can
2 to
repeat
3
it
ml
1
only every
to 2
hourly.
ml every 15 minutes, maximum 3 boluses. That is, you
That
can
is
repeat
per hour.
per hour.
Per hour. Say 2 ml or 3 ml every hour can be given, sir.
That is for
Or
continuous
hourly or
infusion.
90 minutes.
Patient controlled analgesia, it is 2 ml per hour. And for intermittent
Yes, sir.
infusions, you can repeat every 15 minutes for 1 hour, only 3 boluses, 1 to 1.5 ml every
Per hour.
15 minutes.
every 20
No,
minutes you can give.
First hour, you can repeat 1 to 1.5 ml every 15 minutes till the desired effect is achieved.
Right.
Then you can have a continuous infusion of 2 ml per hour.
Yes, that is when you are using it as a continuous infusion.
Yeah, that is for continuous. For intermittent boluses, you can titrate the doses.
Yes, of course. That is
Every
true.
15 minutes, you can use a top-up of 1 to 1.5 ml, including 2 micrograms per ml of fentanyl. Either
Yes.
0.1% ropivacaine or 0.625% bupivacaine.
Bupivacaine.
There are many questions in the chat box. To Ravindra sir, which agent would you prefer after patchy spinal?
Which agent would you prefer after?
Patchy spinal means suppose you have used one drug and the spinal action is patchy, then would you use the same drug or you would like to change the drug?
See, I have always used the same drug.
Okay.
I'm a strong proponent of bupivacaine, and I have always used bupivacaine as in the repeat spinal also, and it does act.
What is your experience with ropivacaine, sir?
Ropivacaine I have used, sir, quite a number of cases, but repeat spinals I have not used.
Of late,
Used
there have
with-
been all these molecules have come. They're more confusing. Ropivacaine heavy has come, levobupivacaine heavy has come. But with experience, I've been using it in different. Even one day, I've used 3 different drugs just to see the difference in the action. But frankly, if you ask me, nothing much except the cost.
Yes.
Yes.
Sir, so
What we can achieve in 30 rupees, the same thing we have to pay 120 rupees.
Sir, so
I feel it's a marketing gimmick.
Every new thing is not always good.
I think
But I
Ravindra
think,
sir has
sir, I
already.
think for this also we'll have to wait for further studies and research.
There is one small difference, sir. I can quote the onset of action with bupivacaine. Yes, sir. Bupivacaine with that of ropivacaine. Bupivacaine is a slightly faster compared to ropivacaine.
Yes.
So similarly, with the same reason why this hypotension developing also is more gradual with ropivacaine.
Yes.
Heavy.
With,
So that is one advantage which we see.
today itself I had given ropivacaine heavy for one bilateral hernia. And that period of that 10 minutes, there is hyperesthesia.
Yes.
Ropivacaine heavy gives immediate action. So while scrubbing the patient, they're very, it's not a very comfortable feeling because of the hyperesthesia.
Very true.
So
I think you need to wait for some time before you allow the surgeon to do anything.
And sir,
Relaxation is less with
So
ropivacaine.
not good for obstetrics also, for LSCS.
Certainly not.
Sir, what about levobupropion? Do you think the action is delayed? Onset of action?
Compared to the routine ropivacaine, yes. Ropivacaine is more, maybe about 8 to 10 minutes also.
Oh.
Next question.
Next question is
about lateral position.
Yes.
If there is inadequate action, sir, I think this is a question to Ravindra sir. For giving lateral position in case of inadequate action. But if we give lateral position, then there is a chance that there will be unilateral action.
Yes, see, with the heavy solutions that we use and with the volumes that we use for a surgical anesthesia, pure unilateral blocks are almost not there at all. Pure unilateral blocks.
Agreed.
Of course, there is a differential block. Maybe on the non-dependent side, the level of the block may be about 2 segments or 3 segments less than the dependent side. So I think that is not a very big thing. All that you need to do is add about 0.2 milligrams, about 1 or 2 milligrams more will give you the sufficient level of the block. So barring that, the level goes up in the sense the drug reaches the thoracic levels. And then you put the patient in the supine position, the spread occurs a little later also. So it becomes uniform.
I would add still further that even what the little difference that you're saying only lasts for a few minutes. Let us say if you say it after 10 minutes, you might feel the little differential
may not be there
for the height of the block, but half an hour later, that also is eliminated.
Yes, sir. Sir, what about the speed of injection? How it speed of the injection?
See, one must not forget that the CSF is constantly circulating. Okay, with the passage of time, even if you've given a relatively smaller dose and you waited for, let us say, good 10 minutes in one gravitational position, you will not get a pure, as the previous speaker said, a pure unilateral block because of the circulation that the CSF has. So it equalizes the whole thing. Unless the straddle block, sitting position, 10 minutes, L5S1, and a dose of 0.5. Even in those cases, I have seen in the recovery area, it's no more unilateral. Maybe in the theater, it's unilateral.
Is there any factor of speed of the injection?
Yes,
this,
yeah, you're talking of the force with which you do it.
Let me answer that question, sir.
Yes.
See, when we were postgraduates some 35 years ago, the factors that influence the spread of the local anesthetics, all textbooks used to mention the speed of injection, the direction of the bevel, the barbitage, all of them used to be a factor. Now, if you see the textbooks and the references, the only factor that matters is the mass of the drug. Now,
the reason is very obvious.
That is for the ultimate level of the block, as Dr. Bhatia puts it. After about half an hour's time, nothing matters.
Listen.
The speed of the injection does not matter to any extent. As you said, that the CSF is circulating.
As a resident, I used to use a 21 number needle. Today, I'm using a 27 or a 29 number needle. The speed does not matter much.
Is it
how much of a speed can you gain through a 27 and a 29 number needle? We were using 20 number needle. There the
for segmental spinal, it affects. Is it affect for segmental spinal?
No. No, I don't think. I don't.
To a certain extent,
I-
segmental spinal, it does affect, sir.
Yeah.
Okay.
Because see, if you compare the continuous spinal versus intermittent boluses, with intermittent boluses, the spread is better than continuous spinals. The spread
Yes.
is better because the speed of injection is less. To a certain extent, yes. But when you compare it with a large volume blocks of spinal, like for a hysterectomy, you are giving, say, about 3 to 3.5 ml. That's about 15 milligrams to 17 milligrams of bupivacaine at L3-4. You inject it fast, you inject it slow, the level of the block will remain the same.
What I meant was the speed gets eliminated when you push the syringe through a 27 number needle and when you push the same syringe through a 22, 23, 24 number needle.
Yes, sir. I agree with you, sir.
Okay. Thank you, sir.
Hello. Can I say
Sir.
something?
Yes,
Yes,
sir.
sir, please.
Paliwal, sir, please.
Yeah, there are many misconceptions about this dose and this thing. Many times it is also dependent on the site of injection. Like you see in segmental spinals, the low doses given at higher levels can produce the same effect which lumbar levels cannot produce. So, and the currents, they, even though they are temporarily created by barbotage or this thing, but they settle down immediately. And most of the things, like for hyperbaric drugs, it depends on the gravity for spread. And isobaric drugs, they depend on the site of injection and the volume of the drug which is given. What happens at the lumbar dose is when you give a spinal at L3, L4, most of the drug goes to the sacral level. But if you give at the tip of that lordosis curve, that is at L1, L2 or L2, L3, the half of the drug goes down and half of the drug goes towards the thoracic
Sacral.
level. So that is many times a reason for failure. Even if you give 3 ml of the drug at L3, L4, you may not achieve the same effects which you can achieve with just 2 ml. I never use more than 10 milligrams for hysterectomy, and I still get levels around T6, T4. That is just because I puncture the dura at L1, L2 or L2, L3.
Yes.
I never use.
I think I gave that this demonstration of some of the slides I showed that
Very
also,
nicely given.
how it
Yes.
how it's
And most of the times the things, they remain, I mean, unilateral when you use a very low doses. When you increase the dose, the whatever drug is remaining which is unused, that can move up to 2 hours by change of positions. So most of the times the excess drug which is there, which moves with the bulk moment of CSF and causes this bilateral spread. But if you use just 1 ml of the drug and keep the patient in lateral position, then you will find that there is mostly a unilateral
differentially unilateral.
Yes. That depends on the dose.
Dose. Dr. Poonam,
Agreed,
Dr.
sir.
Poonam, madam, unmute
Yes,
yourself.
yeah. Good
Yes.
evening. Good
Yeah.
evening, all the speakers today and seniors and friends. It was a very excellently delivered lecture by both the speakers. My question is to Dr. Ravindra, sir. Sir, regarding the failed spinal, like the truly failed spinal described by you, defined by you in the lecture. Suppose there is a true failed spinal, say from LA resistance. Can we replace the local anesthetic altogether by, say, intrathecal opioid, for example, pentazocine, and achieve the effect of spinal anesthesia? Similarly, there have been reports, not only anecdotal, but in the recent past, there have been case reports where people have used intrathecal pentazocine to achieve spinal anesthesia. Is that a possibility? And can you share your experience regarding this, please, sir?
Yes, sir. Yes, truly. Pentazocine, I'm not a big fan of pentazocine intrathecal, but ketamine has been used. I have used ketamine in a patient in whom there was a proved resistance to local anesthetic resistance earlier itself, with a history of scorpion bite. Nothing could be, his dental extraction was terrible on 4 or 5 occasions, and we had to do something for him. We were contemplating general anesthesia, In the last minute, it was a short urological procedure. We decided to give ketamine. Ketamine was useful. So
Yes, yes.
other drugs, I think I mentioned a little while earlier
Mhm.
that there is a mechanism of action for local anesthetics to act. These additives act in a different way. So the local anesthetic drugs, all the local anesthetics, if there is resistance to bupivacaine, probably there will be resistance to levobupivacaine as well as for ropivacaine also. But maybe the other additives like ketamine, opioids, all of them act in a different way. Maybe that is a good choice.
I'll give
They have
you
a
my
systemic effect
experience.
actually.
Sir.
I broke all the norms in one case. I gave a spinal with a bupivacaine. It did not act at all. Breaking the norms within a matter of say 7-8 minutes, I gave the same spinal again. Okay, it did not act at all. I broke again all the norms and gave the spinal the third time with 5% xylocaine. It acted completely. So twice it did not act with bupivacaine, but once when 5% xylocaine was given, it acted completely.
Okay.
The dictum actually is whenever there is a failed spinal, either you change the drug, either the site or the operator. This is a dictum by which I tell to my
So
junior
maybe the
colleagues.
question here is the change of local anesthetic rather than the same variant of the same local anesthetic. Now, will that make a difference?
My experience with ketamine intrathecal is that after 1.5 ml of ketamine, the patient was deeply sedated.
True, sir. It happens.
Yeah.
Especially in elderly, it is a very difficult situation to manage. So you'll have to manage the airway in a very, very meticulous way. Very meticulous way.
And how much ketamine to be given intrathecally, sir?
Yeah, say about 50 milligrams
50
to
is the
75
maximum.
milligrams.
For fracture neck
50
femur,
to
I had
60
given 1.5
milligrams.
ml.
Yeah, 50
So
to 75
is there a good sensory and motor blockade, and would there be a sympathetic blockade as well? Like ketamine, it seems to be paradoxical, but will there be hypotension after ketamine given intrathecally?
The autonomic blockade is extremely low. It is not there at all. In fact,
Yeah,
the
thought
blood
so.
pressure goes up. In
Right,
fact, the
right.
blood pressure goes up. And
So more
motor
of a
blockade
sensory block.
also is minimal. There may
More of
not
a
be any
sensory
motor
block.
blockade also.
That
You may
action
not
lasts
get relaxation at all.
only for 45 minutes to 50 minutes.
Yes,
Mhm.
very short duration of action. Sensory blockade only. Motor blockade is very minimal, and autonomic blockade almost not there.
Okay. Thank you. Thank you.
And
all
as
seniors for
he
sharing the
rightly
experience.
mentioned, sedation is extremely dangerous. It can cause extremely bad sedation.
Right,
With
right. Thank you.
intrathecal ketamine.
All the time I was pinching
Yes,
the patient and
intrathecal.
make him awake.
Yes.
That was
Yes,
my
thank
first experience of ketamine.
Even though the sedation is there, the airway tone and this thing is usually maintained. So usually not a
Good.
problem with ketamine.
Yeah,
Tone and
true.
integrity is usually maintained.
All the time I was afraid that whether this patient is going to be awake or not.
And this is only occasionally. That was a little higher dose you have used. Otherwise, with 50 milligrams, it is not usually an issue. Even we use Dexcat also intrathecally for better results. Little bit of Dexmet and little bit of ketamine for superficial debridements and all. We have tried that also. Very good results.
Works very well.
Without any
And how
local
much
anesthesia.
ketamine? How much dexmet and how much ketamine?
Just 5 micrograms of Dexmet and 25 ketamine.
Okay.
Just for superficial
Diluted or
debridements and
how much? That much amount? How that you have to use insulin syringe?
yeah,
Oh,
you have
yes.
to calculate the exact dose with the insulin syringe about Dexmet because even a little bit of more, one drop even will, 2 micrograms or 3 micrograms.
Yeah.
So you have to calculate accurately with insulin syringe or just rinse the syringe with, depends. If you are using 1 ml syringe, 2 ml syringe, so it will be 2 micrograms, 3 micrograms, 5 micrograms or 10 micrograms, depending on the syringe you use. The dead
1
space
ml
is
syringe.
according.
Yes.
On 1 ml syringe, it is 2 micrograms roughly.
Yes.
2 ml syringe,
Okay.
it is 3 micrograms. 5 ml syringe, it is around 4.8 or 5 micrograms. Accordingly, the dead space is there. You can roughly just rinse the syringe, add ketamine to it, and give it.
Yes, sir. Thank you.
Any
Okay,
more
thank you.
questions in chat box?
Yes, there is a
I
question
do-
that for saddle block, how much drug would you use, sir? This is for Ravindra, sir.
1 ml,
1
1
ml.
to 1.25 ml,
These
5 to
people
7
are doing
milligrams of
these
bupivacaine.
people are doing staplers quite frequently, and I've noticed that about I used to give 1 ml of hyperbaric, make them sit for about 10 minutes. But with staplers, when they are crushing it, the patient has some kind of sensation, maybe because of pulling. So for stapler hemorrhoidectomy, I've started giving a little more, and not true saddle. I make them sleep in about 4-5 minutes, especially in stapler hemorrhoidectomy.
If we add fentanyl, I think this problem is not seen.
Very truly.
Sir, have you
For
used
saddle
2%,
block, I always add fentanyl, about 10 to 15 mics.
2% xylocaine for intrathecal sterile 2% xylocaine? That ampoules were available 2-3 years back.
Not heavy?
Yes, heavy.
No.
I don't know, sir. I have no experience with it.
Xylocard is preservative free.
No.
Xylocard is preservative.
Ampoules of 2% xylocaine. That means for spinal anesthesia, intrathecal only.
Heavy?
Heavy.
I don't know, sir. I have
No,
not
heavy,
used it.
heavy point 2% I have not seen. 5% it's still available.
Not seen, sir. I have no
Still available. 2% were also available. We were
2% is
using it for
hypobaric.
that saddle block.
2% is a hypobaric drug. This is the only solution which is truly hypobaric.
Yes, sir.
Yes.
2% xylocaine, which is actually not available, but xylocard, which few people use, it is truly hypobaric. This is the only solution. Otherwise, the available isobaric solutions like cleobupivacaine, ropivacaine, they are on the verge of being hypobaric, to act like isobaric. If you add a distilled water to it, then it will become hypobaric. And for anorectal surgeries, you can use these hypobaric drugs.
Yes.
Jackknife position, if you want to give spinal, you can use this.
Thank you very much, sir. It's almost 9 o'clock now. Manisha madam, we will stop here or continue the discussion? It's
Hello. The discussion is going to be very interesting, but I think most of the queries have been solved, and we can keep only one session for a discussion on spinal anesthesia in the coming week after Diwali.
Festival season.
Yeah. Both the topics were so nice, like failed spinal
Yeah.
as well as continuous spinal. So the discussion is going to go on, but I think now at the end of 2 hours, we can see almost 60-70 people still logged in. So that shows the success of the webinar.
Thank you very much, madam.
Thank you.
Thank you.
Thank you very much, and wish you all a very happy Diwali.
Thank you. Thank you all.
Yeah.
Thanks a lot. Thanks a lot. And
Avinash,
happy Diwali.
Avinash,
Yes,
just
yes,
the formality
very
of
informative lecture and very excellent presentation by Dr. Ravindra sir and Rajesh Rao sir. I thank both of you on behalf of Maharashtra State ISA chapter. I also thank Dr. Sadhana Kulkarni madam and Pushpa Agrawal madam for chairing this today's session. I also thanks for the gracious presence of for today's webinar, Dr. Bhatia sir, then Dr. Badange sir, Dr. Haran Kedkar sir, and all the members of Maharashtra State ISA who joined for this webinar. I thank all of thank to the Varsha who managed this today's webinar, and wish you all happy Diwali. Thank you.
Yes, happy
Thank you
Diwali
very
to
much.
all.
Thank you.
Happy
Thank you
Diwali
so
to
much.
all.
Thank you so much.
Thank you.
Thank you,
sir.
Manisha, for giving opportunity.
Thank you. Thank you, sir.
See you all
Thank
in
you.
Mumbai.
Thank you very much.
Yeah.
Thank you, sir.
Thank you. Okay. Good night, all of you.
Good night.
Good night. Good night.
Yes.
So,
Varsha,
shall
please
we
stop
leave now?
recording.
Yes, sir. Please.
Yes, sir.
Please,
Yes,
sir.
sir.
Please, sir.
Thank you so much.
Thank you, sir.
Yes.
Sir, I'm very happy that I waited patiently till you finish your or whatever you had your commitments, because it was so excellent.
Thank you very much, madam.
This lecture, in fact, was we had decided it in the month of October, but then sir had some commitments, family commitments, and I waited, and I'm very happy for that, sir. Thank you so much, sir.
Thank you
Dr.
very
Rajesh
much.
Rao.
Thanks a lot, madam.
Yeah,
Thank you.
It's my pleasure. It was my pleasure.
Okay. Thank you.
Avinash, sir, you can end the meeting now.
Yes. Yes, ma'am.